Well, wonderful, and thank you everybody for tuning in today. This is our third OR session for 2023. My name's Kathryn von Treuer, and I'm from the Cairnmillar Institute. And I also have with me today Associate Professor Alex Bahar-Fuchs, also a senior clinician at the Cairnmillar Institute, but also has another role at Deakin University as well. And today we're talking about the topic around helping yourself and others with memory, but the topic's also a little bit broader than that, talking about different various cognitive aspects of aging. So what we mean by cognitive aspects of aging is we're talking about and referring to how the mind changes and develops as we get older. We're talking about cognitive ability encompasses everything to do with thinking and memory and intellect, including things like how we make decisions. So I welcome Alex to this session. So just for the next slide, thanks, Alex. So we are running a webinar today, so you are welcome to ask questions. So you won't be able to speak and we can't hear you, but you're certainly welcome to type in a question. So all you need to do is go down to the chat box and click on that at the bottom of your screen, and you can add in a question there. We're going to save the questions till the end of the session. So as we go along, feel welcome to pop in any questions you have, and we can answer them then at that stage. So thank you. So I'd formally like to start with our acknowledgement of country. So the Cairnmillar Institute, we acknowledge the traditional owners of the land on which we are meeting here, and indeed wherever you may be tuning into this session. We pay our respects to the elders, past and present, and the Aboriginal elders of communities or anyone who might tune in today. So we extend this respect to all Indigenous peoples from around the world and any First Nations people who come across the below material. And of course, we are providing this series also in memory of Emeritus Professor Francis Macnab, who inspired and helped commence the OR program and this suite of seminars that you will receive today. So we thank him for his inspiration and his legacy. And so now I would like to hand over to Alex. And Alex is a senior psychologist, as I mentioned earlier, with the Cairnmillar Institute. He's an experienced clinician and researcher who is particularly passionate about healthy cognitive ageing and the treatment of people with or at risk of dementia. He's a leading Australian and international authority on cognitive interventions for older people, and his work has informed clinical practice guidelines in Australia and beyond. So we're so lucky to have you with us, Alex, today, and delighted that you can come and speak to our OR members. So thank you, and I'll hand it over to you.
Thank you so much, Kathryn. It's a real pleasure to have the opportunity to give this talk, and it's an area, as you said, that I'm very passionate about. We all experience difficulties in everyday memory, I guess, so that's not something restricted to older age, but certainly in my line of work, I am interested in healthy cognitive aging, in reducing risk of dementia, and in living well with dementia for those who are affected with dementia. So in my talk, I'm going to cover just a few basic concepts, helping those who might not have a clear understanding of the differences between what we mean when we say dementia, for example, versus something like Alzheimer's disease. And then I'll briefly touch on what are some of the available drug treatments, but not at any great length, just briefly. Then I'll talk a little bit about one class of non-drug treatments that we call cognitive treatments. So there's a lot of other non-drug treatments which I won't really cover today, but I'll touch on some of the, I guess, major risk factors and associated lifestyle protective factors. But then I'll focus on these treatments, focus on the way we think, okay, cognitive treatments. So first of all, I get asked a lot by people, patients in the clinic and others in talks, is dementia the same as Alzheimer's disease? And basically, dementia is a word that describes a whole set of symptoms. So it's a syndrome in medical terminology. describes a whole set of symptoms that tend to go together. They involve, by definition, a decline in thinking skills. So this has to be a decline, as opposed to somebody who, for example, had struggled with things like memory or attention or decision making or low intellectual ability throughout their life. That's not what we mean when we say dementia. It needs to involve a change, okay, from previous levels of functioning. This change in someone's memory and thinking needs to be severe enough such that it interferes with their ability to do activities of daily living. Everything from very complex things we do in everyday life, like booking a holiday or managing complex running errands, multitasking, conversing with people, all the way through to more basic things like dressing and showering and the more basic activities of daily living. Or everything involves thinking processes, even if we're not always fully aware of it. So the decline in thinking and cognition needs to be so severe that a person can no longer be fully independent in carrying out those activities. And then the third important element of saying that somebody has dementia is that it's not due to some reversible or other medical condition like a delirium, which is often caused in older people due to urinary tract infections and other causes. So that tends to be acute, it tends to be reversible, and it's not the same as dementia. Dementia is something that can be caused by all sorts of diseases in the brain. Okay, so in this slide you can see some of the leading examples of diseases that can cause dementia. Alzheimer's, by far the better known term, and the disease that contributes to the highest number of cases of dementia, probably about 60%. Okay, but there are other causes. You can see some of them listed here, including vascular disease, disease of the blood vessels and the blood supply in the brain. Lewy body dementia and frontotemporal dementia are other forms of disease that lead to dementia, and they all have somewhat different, I guess, look and feel when they first appear in terms of what are the specific symptoms. Later on, it becomes difficult to differentiate between them, because when dementia becomes more severe and more abilities are affected, then it's a little bit harder to tell the difference between different diseases. But at least in the early stages, often when people come to be assessed, there are certainly differences in the type of difficulties and the types of problems that they have, depending on what is the underlying disease. Now, this is by no means suggesting that these are the only diseases that cause dementia. In fact, we now know that there's probably some 100 causes, diseases of the brain that can lead to dementia, but we won't really go into that today. We'll focus on primarily Alzheimer's disease, or Alzheimer's disease focused with vascular disease, which account for the majority of cases of dementia. Now, many years ago, we used to think that we can only diagnose dementia quite late, when all the symptoms are present. Okay, and that was certainly the case up to about 15 years ago. But we've since been going through somewhat of a revolution in the field, where we have become able to detect the disease in the brain using neuroimaging technology, so very advanced technologies that looks into the brain and can see microscopic changes that appear often long before the onset of more obvious symptoms like memory problems. Okay, this is a very, very common image that is used to explain to people the timeline, the schedule, and what you see is that decades before the development of symptoms, which are marked in green on this graph, so everything that is under the green area is really when we start seeing changes in someone's memory and someone's abilities. But decades before that, we start seeing the buildup of certain pathologies in the brain, certain, I guess, disease processes. The main ones in Alzheimer's disease are called amyloid plaques and neurofibrillary tangles. So these are two types of protein abnormalities. They develop inside the cells of the brain and outside the cells of the brain, and they lead to something that we refer to as the cascade, a chain of events that starts maybe when someone is in their 40s or 50s and very, very gradually builds up. You can see in purple here the buildup of amyloid, followed here by the buildup of tangles inside the cells. And it's only really a long time after, around here, that a person moves from being what we call normal in terms of their cognitive and thinking skills to something we often refer to as mild cognitive impairment, and then finally dementia. In other words, nowadays we regard dementia as somewhat of a late stage of a process that started many, many years before, and we can detect those changes in the brain much, much better than we could before. So that's something that I wanted to make clear. We are drawing a distinction now between a disease of the brain, which we can call Alzheimer's, and a clinical manifestation of a syndrome that leads to dementia. In terms of treatments for dementia, I just wanted to very quickly touch on what's been happening in this area over the past, well, nearly 40 years, really. The first criteria to diagnose Alzheimer's disease were formulated in 1984 by the American National Institute on Aging. But it was only 10 years later that the first, I guess, generation of medications came on the market. And these were medications that didn't really, couldn't provide a cure and didn't really treat the disease itself, but rather these class of medications, which we refer to as cholinesterase inhibitors, they treat the symptoms of changes in memory and thinking, because we know that this transmitter in the brain, which we call acetylcholine, it's implicated in memory processes. So these drugs that were developed in the 90s, donepezil and rivastigmine, galantamine, they're all part of this family of drugs that treat the symptoms, not the disease itself. So what happens is that usually people experience some relief, maybe mild relief from their symptoms. It can go on for a couple of years, but invariably people will continue getting worse over time. It's just that it slowed it down. And again, not everybody responds to these drugs, but enough people respond to these drugs to make them a good initial course of action. Unfortunately, for many years from 2004, really, just trying to see if I can find my pointer. Give me a moment. I know that there is a pointer somewhere, but can't find it. Never mind. Oops, sorry, just go back. It was around here in 2004 that a lot of research started focusing on developing drugs that were different, that targeted the disease itself, the pathology, the amyloid pathology that we believe underlies Alzheimer's disease. And 2 years ago, in 2021, the first such drug was approved in the US at least. And since then, we've had another two that have recently come on what's called the accelerated approval process of the FDA, the American Food and Drug Administration. These are revolutionary drugs. They clear from the brain the amyloid, the very cause of Alzheimer's disease. Okay, and we've seen some very promising results, particularly with the newest drug, donanemab, that just been announced less than 2 months ago. Okay, showing that they are not only clearing the amyloid from the brains of people with Alzheimer's disease, they also lead to an improved clinical picture. In other words, people's symptoms are somewhat better. Their decline is slowed down. So this is a very exciting time, because in the next step, what we will probably see is these drugs commencing earlier on, before people develop any symptoms. Because we know that once people have symptoms, it might be a little bit too late to clear the amyloid. In other words, clearing the amyloid itself isn't enough, because all these other things have already started affecting the brain, the tangles, loss of volume in the brain, inflammation processes, and lots of other things. So it's not enough at that point to simply treat the amyloid. In the next few years, we will no doubt see these types of drugs being given to people who we believe are at very high risk because they have amyloid in their brain, but they don't show any symptoms yet. Okay, and we will see whether, if we start this 10 years or 15 years before the typical onset of clinical symptoms, whether that means that the person will never develop these symptoms. So I think it's a very exciting time. But there are a lot of issues with these drugs that make them very unlikely to become a silver bullet or a cure, or to be useful for everybody, and they are associated with some significant side effects at the moment, not to mention that they are very, very expensive right now, and need to be administered intravenously through an infusion once a month in hospital for a very, very long time. So it's not particularly easy to, I guess, to treat people this way, but it's certainly an exciting time. More important than trying to treat dementia or cure it is our interest in preventing it in the first place, as I said. Okay, this is what we're all interested in. We're interested in not developing dementia in the first place. And that is something that's certainly now seems like a possible reality. Okay, because we know dementia is not a part of aging. We used to think that if people live long enough, they might, or they are likely to develop dementia. We now know this is not the case. Okay, most people are going to live into old age without ever developing dementia. More than that, some people will live into old age with disease in their brain, like even Alzheimer's, and never develop dementia. Okay, because we now are learning more and more about factors that we call resilience factors, things that make people's brains and minds more resilient to the presence of disease. When we talk about prevention, we tend to distinguish between three levels of prevention: primary, secondary, and tertiary. With primary prevention is what we do when there is no disease at all, and we try to prevent it in the first place from developing. Okay. The second stage is when there is some disease already, and we're trying to prevent it from escalating or deteriorating quickly. And the third level of prevention, tertiary, is really about maximizing care, optimizing care, and minimizing what we call excess disability. So people becoming more disabled than what they should be because of other factors. So in the context of Alzheimer's, for example, you can see that when we're talking about primary prevention, it's really from when we're born up until when the early disease in the brain starts showing up in people, which can be in their 40s, sometime in their 40s, okay, which is already where we are entering the domain of secondary prevention. This is what we sometimes call preclinical Alzheimer's disease. There is disease in the brain, there are no signs of it, okay, outside. Finally, tertiary prevention refers to people who are already symptomatic. They are showing signs either of mild cognitive impairment or of Alzheimer's dementia. And this is typically already happening from 60s onwards. Now, I know it's a little bit difficult to see detail in this graph that I'm showing you here, but over the last few years, a lot of very smart people from around the world have come together and have published a very influential paper in a journal called The Lancet, which is a very important journal. This graph shows us what we know about the risk factors for dementia from infancy all the way to old age, and which ones we can do something about. So what the story that this graph tells is that about 40% of all cases of dementia are potentially modifiable, in other words, preventable. Okay, we believe that these lifestyle factors, which I will quickly cover now, add together to about 40% of all cases of dementia. This means that we have a lot of opportunity to intervene and to try and change someone's risk for dementia. And if we used to think that the risks of dementia is something we need to consider in older age, we now know that these risks really start at birth. Okay, so I'll just take you through some of the main ones. The first one we can't do much about, and this is to do with whether or not we're lucky enough to be born or unlucky enough to be born with a particular gene, okay, which is it's called the ApoE4 gene, and if we have two copies of this gene, we are somewhat at risk from birth to develop dementia. It doesn't mean we're going to develop it, but it means we're at an increased risk, okay? And we can't do anything about that. Then from childhood and through adolescence, we know that getting a good education it plays a big role, because some 7% of cases of dementia are attributed to lower education. So targeting, ensuring that people have access to good education is a very important element in fighting dementia. As we go through life and kind of reach to midlife, 40s, we are doing things that are about building our reserve and resilience. This is cognitive reserve and resilience. So this means looking after our diets and doing enough exercise, getting enough sleep, making sure that we engage socially on a regular basis, making sure that our mind is continuously stimulated in particular ways that I'll talk about, okay? At the same time, we want to try and avoid some chronic health conditions that have been shown repeatedly to be associated with Alzheimer's disease. They include diabetes and hypertension, obesity, traumatic brain injury. We now also know that such things as hearing loss in midlife, depression, or heavy drinking, they're all increasing people's chance of developing dementia. Now, this doesn't mean that people who have one or more of these risk factors will develop dementia, of course. It just means that you are essentially at higher risk. And the more of these risk factors one has, the more likely they are to develop dementia. Equally, it's important that I emphasize, not having any of these risk factors doesn't mean that a person will not develop dementia. I have seen many people whose lifestyle really is exemplary in terms of avoiding all of these risk factors and yet develop Alzheimer's disease or other dementia. So, but at least we know that there's some things we can do to minimize the risk. As we get into the later part of life, it's really about continuing avoiding the same kind of chronic health issues and maintaining the cognitive resilience. We also know that exposure to air pollution in later life seems to be associated with increased risk. There are other factors not mentioned here that people ask me about: exposure to metals, certain, I guess, air quality we've covered, but there are other factors that people suspect might be related to dementia, early trauma. Then we don't know for sure. We have a lot of work to do to establish what are some of the other risk factors, but the ones that I've got on the screen here are relatively well established as risk factors. I want to move on now to talk a little bit about what we call cognitive treatments, okay? These are, I guess, the types of activities that one can do anytime in life, but we're focusing now on later life, in order to keep their mind and their brain and their memory active and engaged in a way that helps with memory, but also with other types of processes. So when I say cognitive engagements, all sorts of things come to mind, right? From visiting museums, to doing yoga, to learning languages and doing Sudokus and puzzles, to playing chess and other kind of games. You can see the lady on the top right who's playing the drums, which is my little favorite hobby as well. I believe it's a great protective factor against memory loss. And, even those of you who are here in attendance and listening to this presentation are already engaging your mind and intellectually in a helpful way. So these are just examples, right, of what we call cognitively engaging activities. But in order to make a little bit of sense of it for us professionals, we tend to classify things into slightly neater categories of activities, which I've listed here. Okay, we've been referring to them as cognitive stimulation, rehabilitation, and training. And I'll say a few words about what I mean by those. Okay, and we've been collectively referring to these as cognition-oriented treatments. These are treatments that are focused on someone's thinking skills. So when we talk about cognitive stimulation in everyday language, it's very much these types of images I just showed you. Everything we do that engages the mind is a cognitively stimulating activity, okay? But in the context of dementia prevention or dementia treatment, we have a more structured therapy called cognitive stimulation therapy. This was developed by some colleagues, esteemed colleagues from the UK, okay? And it's a really evidence-based approach which follows a structured and manual process. It emphasizes general mental stimulation and introduces lots of activities designed to be fun and pleasant, and improves overall well-being of people. It follows a program that runs over 14 sessions, which can then be followed by maintenance sessions. However, this type of approach is being usually done with people with dementia. People who already have dementia, often living in residential care, okay? And it doesn't usually get administered in this way to people without dementia, although it can. These are just some of the principles of cognitive stimulation therapy. The focus is on ideas and on opinions rather than on facts. It's very much about having fun. It's very much about using memory clues and things like reminiscence. A lot of focus on orientation, helping people who may have struggled with orientation, keeping oriented to day and time and date, location, and so on. So these are just some of the key principles of the approach. Another approach which I use in my clinic working with people is called cognitive rehabilitation. This is also something that is usually targeted towards people with dementia, okay? And it comes from a tradition of working with people with traumatic brain injuries or strokes, and really is focused on trying to help people stay independent for as long as possible by choosing and focusing on the activities and the roles that mean the most to them, okay? For one person, this might mean remembering the names of members of an exercise club or a book club. For another person, it might mean continuing to be able to read to a grandchild, okay? Every person has something else that makes, that is meaningful to them, and I guess is important for them to preserve for their identity, for their sense of purpose. And cognitive rehabilitation is really all about that. It's about not trying to cure, not trying to improve abilities across the board, but rather trying to help a person identify what are the most meaningful roles they play, what are the most meaningful tasks or activities they want to continue engaging in, okay? And when working with people using this approach, we build on their existing strengths and resources and residual abilities. Even when people lose memory and other thinking skills, they still have some residual abilities that we can build on. And we try to minimize this concept of excess disability. Imagine somebody with dementia who can't remember information very well, and because of that becomes a little bit anxious or a little bit withdrawn, or doesn't want to participate in certain activities because of that. But this might be to do with their self-esteem or with their confidence or with their mood, rather than with the dementia per se. So the goal here is to try and minimize this excess disability. And unlike cognitive stimulation, which tends to be delivered in groups, cognitive rehabilitation is inherently a highly individualized and person-centered framework, which we call an enablement framework, and is highly person-centered. Okay. The cornerstone of cognitive rehabilitation is setting goals. which we refer to as SMART goals. Okay, you can see what we mean by SMART goals here on the right. Goals need to be specific, they need to be measurable, attainable, they need to be relevant to the person, and they need to be timed. Okay, so in the intervention, I work with people targeting directly those aspects of everyday life that they want to focus on. And at the moment at Carnmillar, I see a number of clients that all have dementia, and they all have different goals that I help them and their families develop and articulate, and we write them down, and then we use every evidence-based technique that we know works to help the person and their family reach those goals. For those of you who might want to know more about goal setting, there's a fantastic resource that I've listed here called My Life, My Goals, developed by my mentor and colleague from the UK, Professor Linda Clare. She's the pioneering person in adapting this technique of cognitive rehabilitation from working with people with stroke or brain injury to working with people with dementia. And you can just Google it. If you go My Life, My Goals, Living with Dementia, it's a fantastic workbook that people can use to help them define such goals and learn some strategies to work towards them. Finally, the third of the approaches that I want to touch on is one that we refer to as cognitive training. This is a little bit more like a brain gym, okay? This is what I do a lot in my research. This approach focuses on actually exercising the brain muscles more formally, okay? Abilities like memory or attention, speed, and other types of abilities get practiced really heavily using tasks that look like games. I'll show you an example in a moment, okay? And these tasks get harder the better a person does, because the idea is to always keep them challenged, make sure that they are challenged, okay? And the tasks, they look like games, but they really reflect those underlying skills that I've mentioned, like memory and attention and other skills. The idea here is that if somebody gets better at doing a task, we believe that they're going to be better at doing other tasks that rely on that same skill. Because in cognitive rehabilitation, I didn't say it explicitly, we focus on very narrow activities that are important for the person. We don't assume and we don't expect that improvements in one area will lead to improvements in other areas, okay? In cognitive training, it's a little bit like when somebody goes to the gym and exercises a group of muscles. We believe that those muscles will be improved in different contexts and will be, allowing the person to function better in all sorts of contexts. So that's the same with cognitive training. And we make a difference between two main types of ways of doing this. One is the so-called drill practice, and I'll give you an example. And the one is to do with more learning strategies and applying them. Strategies can be either internal or external. So in cognitive training, we usually nowadays use computers, okay? Computerized cognitive training. Years ago, we used to do them on various pen and paper tasks, but nowadays it's primarily through the use of computer programs. You can see on the screen a wide range of computer programs that are in the market. There are many, many more. I've just listed some of the better known ones. They are based on similar principles, okay? They all offer games that really challenge you, and they can be fun, not always, but sometimes, okay? And I don't endorse any of them in specifically, but some of them have got better research evidence behind them than others. And then we have some fantastic universities around the world that have centers that are fully dedicated to the development of such games for the public, like this one from University of California. It's called the Brain Game Center. And one of my colleagues is the director of this center. And they develop just fantastic games, both on the computer and through apps, all aiming to improve people's thinking skills, and are free. The kind of programs that are on the top, they tend to be subscription based. It means you need to buy a subscription for them. Here's an example of how a task may look like. Okay, so imagine that you're looking at a computer screen, okay, and there's a set of water lilies, and the computer takes a turn in showing you these lilies lighting up in a particular order. Okay, one of them will light up in turn, and you need to remember that sequence. Okay, so what we're practicing here is our attention, our visual attention, and very short-term memory. Then it's your turn, and you have to repeat the same sequence. You have to click on those lilies in the same sequence that you saw them lighting up before. And if you do well, the computer will give you more lilies to remember. Okay, here there are 4, and so on and so forth. The amount of information to recall will increase if you do well. And if you don't do so well, it will go back to being fewer to make sure that you are practicing at the right level for you. So here's an example that is about visual attention and working memory. Another example is this one, more focused on reasoning and problem solving. So here you see an object, kiwi fruit, which gets scrambled. And then the task is to try and put this object back together using the minimum number of steps. You have to know how the object should look like. You need to know what pieces to move in the most effective way to reassemble it. So it's involving reasoning and working memory as well. So these are just 2 examples of most of these programs will have dozens and dozens of games of this type of nature. And they often will assess a person to get an idea of where are the person's strengths, where are the person's weaknesses in terms of their abilities, and the type of tasks that will be provided will be those that need to be improved, skills that need to improve. I hope that makes sense. And then we've got these tasks, these so-called strategy-based training, where sometimes also called meta-cognitive training, because what we're trying to learn here, rather than just repeatedly completing a task, we're trying to learn a principle of how to remember information better. Okay, and I'm going to show you an example of one such technique that we refer to as space retrieval. Very simple technique, effective with people with dementia, without dementia, in fact, with any age. And it's really useful as a technique if you want to learn how to remember small amounts of important information for really long periods, like names or a PIN number or a password, and so on. And it's just a simple idea of recalling the information at increasingly long intervals. And I'll show you how it works. If you were now to write down, for example, a password or a PIN number, okay, and you write this information down, and then you cover it straight up, so you can't see it anymore. You then say it to yourself, okay? Say that the number I tried to remember was 3749, and I write it down, and I cover it up, and I say 3749, okay? Now, I check if I was right by uncovering the information. If I was correct in my recall, I go ahead and I increase the time. Very, very small. I add 30 seconds, okay? And I repeat the sequence. I will cover it up. I will wait 30 seconds. I will say the number. I will check and see how I go. However, if you were incorrect when you looked at what you said, you reduce the time, okay? You try and make sure that you are able to remember the information. So this process gets repeated. You say this to yourself, you cover it up again, and you say it to yourself. So I have shown people with dementia who can't remember a lot that using this simple technique, they were able to learn meaningful information. One of my clients was able to learn her daughter's number, who even her husband doesn't know, okay? But she, with dementia and without being able to learn and remember a lot of information, using these techniques with me in the session and practicing it at home, was able to learn her daughter's phone number and hold on to it for months. Now, I should also emphasize, there's no magic here. If the person stops doing it, the information will eventually fade away again, okay? But it's just important to demonstrate that using these techniques, a person can learn and sustain memory for things that are meaningful to them. I'm not suggesting this can be used for every day, for everything, but it's certainly useful for specific information. Another type of technique is called mnemonics. This is when a person learns to form kind of various associations in their mind, visual imagery, for example. And it's a little bit hard to see a detail here, but this is from a work of one of my friends and colleagues from the University of Michigan, Benjamin Hampstead, who helps people remember where things are in the house. People tend to misplace things, right, in the house. And he helps them by helping them think of a feature like a piano in this picture here, and a reason why the objects might be on the piano. Here he says, okay, imagine using a pen to make a note on the music sheet while playing the piano. Okay, so it's a feature and a reason, and putting them together. And if you practice this with people when they are forming these mental associations, sometimes with rhymes, sometimes with all sorts of other cues, it certainly helps them remember information better, and there's plenty of evidence showing that this works. But it requires more effort. Unlike those games that I've shown you that really are about practicing through playing, these types of techniques are a bit more effortful. People need to put effort initially to get in the habit of using such a strategy. But once they do, and if they manage to acquire and master the technique, it's likely to help across different situations, not just in one situation. And the mnemonics that I just talked about are an example of what we refer to as internal strategies. We are practicing things in our minds. Another type of strategy-based training involves external strategies, compensatory strategies. This includes, but is not limited to, things like using signage, all sorts of personal memorabilia, color coding things, contrasting them by different lights, decluttering, okay, forming categories or stations for specific things. And you can see some examples here in the pictures. Again, very, very simple, very useful. And I think the more people's memory problems are severe, we probably rely more on these types of external memory aids over mnemonics and more effortful memory aids. Then we've got these fantastic groups that are really, really popular in Australia and across the world. These are groups of skill building, memory skill building. They in Melbourne, we have one which is very popular called the LATCH program, which stands for the La Trobe University and Caulfield Hospital, a memory program. Okay, these are programs that run over anything from 6 to 10 weeks, typically in groups of people who either have a little bit of problems with their memory, or maybe they don't, but they're worried about their memory. Okay, and the groups tend to be at least a couple of hours each session. They are led by an experienced facilitator, typically a psychologist. Okay, and it involves a lot of education, a lot of psychoeducation, a lot of principles of therapy, like cognitive behavior therapy, to help people change their attitudes and their beliefs around things that might stand in their way from, I guess, making the most of their memory. There's a lot of practice in the session of some of the strategies that I've mentioned before. Okay, and people are provided with homework of what to do at home between sessions so that they keep practicing. And of course, it's got a fantastic social element to it. People really enjoy coming together, sharing experiences, sharing techniques and strategies that work and that don't work. And I think it's a really fantastic way to to achieve better quality of life. This shows you an example of how the Latch program looks every week. People who are interested in Melbourne in the Latch program can certainly reach out, and there's ways to access it through, for example, Dementia Australia. It includes sessions focused on some education around memory and how it works, reasoning for why memory fails, understanding concepts of like prospective memory, remembering how to do things in the future. Okay, and then we have practical sessions that focus on difficulties in memory in conversation, how to remember numbers and words, learning new information and technology, and so on and so forth. So a very successful program, and we have certainly talked at Carnmillar about possibly looking to set up one such program ourselves, and we might still look into that in the future. Before I finish, I'm coming to the end of what I wanted to talk about. There are also unusual ways of training memory, okay? In my area of research, for instance, I've been very interested in the sense of smell and how that relates to memory. And some of the work that me and my colleagues are doing right now tries to understand whether if we were to train our sense of smell, whether that can have a positive impact on our memory. Most people will be aware that there's a very, very strong link between smell and memory. How many of you have this experience of smelling something that really brings strong memories to mind? It's not a coincidence. It's because memory and the sense of smell are living in the same part of the brain. Okay, we are running a very interesting study right now at Deakin University called the Mind Your Nose study, where we are helping people train their memory for smells. And we are doing this quite intensively. So people get trained every day at home for all sorts of smells. It's a cool game. It's like a memory game using the sense of smell. And what we're interested in finding out is whether memory gets better after this program more broadly, not just memory for smells. So we are currently looking for people. We are still recruiting participants for this study. They need to be over the age of 65. They need to have some concerns about their thinking and their memory, and live in the metropolitan Melbourne area. And if anybody wants to find out more information about this study, do feel free to reach out to me through the Cairnmillar Institute, and I can provide you with more details about this study, which is funded by the American Alzheimer's Association. So, in conclusion, I guess my key take-home messages from today's talk. First of all, healthy aging and dementia prevention is something we need to start at birth. Okay, we need to educate our kids about it. We need to be very, very mindful that we don't start sort of taking action to prevent dementia when we reach our 60s. And the more we are aware of it early on, the better, the more likely we are to engage in all those activities that we now know affect our brain well into older age and make it more or less likely to stay healthy. I've also wanted to remind you that we have this very exciting new generation of drug treatments that are coming on the market in the coming years, and they will be a game changer. Okay, I'm not saying that we have all the answers and solutions, but they will certainly take us to a very exciting place in terms of hopefully preventing dementia or really slowing it down. And then in the second part of the talk, I wanted to encourage you to think about the types of cognitive strategies that are out there, whether it's formal through training, whether it's through a computer, whether it's through learning some mnemonics or using external aids and participating in a program. These are all really effective ways, all backed by evidence, to, if not always prevent dementia, really increase people's quality of life, really help them live better even with dementia, which is no less important. And like with other chronic health conditions such as diabetes, which we don't cure, but we live with, okay, effectively, much of the same shift in mindset is happening in the dementia space, where we will learn to live better with dementia and for many years, and in a way that still people feel is meaningful and vital. So with that, I will say thank you, and I'm open to take any questions, and I hope that you find it useful.
Alex, there is a question in the Q&A section where someone has asked, can interacting with a trained wellbeing dog assist with cognitive training and other activities?
I think that there is plenty of evidence around the value of pets and of I guess more dedicated animals like dogs. I don't know enough about it, but I certainly think that it covers a few grounds simultaneously. Certainly a social of sorts connection, okay? Certainly there's ways that dogs can help in some ways with our cognition as well. And there's going to be a lot of interesting developments in the artificial intelligence space coming in the years to come, because we are already seeing certain types of companionship type intelligence that will do an amazing work in keeping you not only company, but also providing very, very individualized, very tailored type of intellectual stimulation for people. So yeah, I think certainly something that's worth trying.
I think we're still learning very much in the space, aren't we, in terms of the roles of animals assisting us with our quality of life. And people might recall from our earlier conversations with Stephen Kosky, who talked about the different elements of bliss and how memory, and Alex mentioned the quality of life with memory as well, all sort of feed into each other, that, you know, they're components to our life as a whole. So I don't think there's any other questions there, but thank you, Ros, for that question about assisted animals. And that's really helpful. And thank you so much, Alex, for your time and sharing your wisdom and ideas with us too, in terms of helping to sort of support our development of our memory as we're aging. So thank you sincerely very much.
Thank you.
It's a bit of a different pace, this conversation, compared to the last two we've had with Stephen, and but still very, really valuable. So thank you so much.
My pleasure, and thanks for the opportunity again, and we'll no doubt keep the conversation going.
Absolutely. Yeah, thank you.
Okay.
Pop on to the next slide. Thanks. And just a reminder to people to let us know how we did today. We appreciate hearing your feedback. So there's a survey link that you're able to sort of access on the invitation. And if there's any topics that you would like covered in the future, please feel welcome to send them through. So that'd be very much appreciated. And then also remembering that we provide these seminars for free, but people are also welcome to help support our Big Tent project. So we're actually starting up some new groups very soon in regards to our work with mental health and wellbeing of children who've experienced trauma. So we're starting up some new groups in the Narre Warren area. So people feel welcome to donate by using the QR code on the screen or going to the web address to do so. But there's certainly no need to have to do this, but we appreciate it. It's also another initiative from Emeritus Professor Francis Macnab as well. And it's actually been going for 30 years, which is a long time for any initiative to be going. And just the final slide. Thanks. And so join us next month as we discuss the courage to claim your unlived life. And that will be on the 5th of October. So thank you everyone for your time today. Thank you again, Alex. Much appreciated, and have a good week, everybody.
Thank you.
Thank you.
Bye.